conversation and very, very engaging as well. Thank you for spending the next 1 hour, 30 minutes with us, and we look forward to your engagement. Just before we proceed, just a little housekeeping. We would kindly request that you keep your microphones off while the speakers are presenting to avoid any interference and distractions while they are presenting. We would also request that when we have the question and answer session much later in the event at about 12:45 or 1 p.m., if you have any questions before then, please put your questions in the chat, or if you would like to speak during the Q&A session, we'll call on you if you use the raise your hand button, and we'll call on you. Again, just a reminder to keep your microphones off once you get into the meeting. Thank you very much. I would now like to kick off the program by calling on our host and the chair of the ILA Nigeria Committee on Women, International Law and Development, Dr. Pedi Obani, to give her welcome remarks. Pedi, please.
Thank you very much, Ire, and I hope everyone can hear me.
Yes, we can.
Excellent. Thanks for confirming. Good day, everyone. Our distinguished speakers, colleagues, members of the International Law Association Nigeria branch, our partners, and everyone who's joining us today. It is a privilege to welcome you on behalf of the Committee on Women, International Law and Development to this timely webinar on women's rights and access to healthcare, unpacking the myths. This is more than a discussion about healthcare. It is a conversation about justice, equality, and the extent to which our legal systems promote access to one of the fundamental promises of human rights, that is that everyone should have access to the highest attainable standard of health without discrimination. It also reminds of the responsibilities which both private and public institutions bear towards achieving this promise. Healthcare itself is very often described as a service, but for women, access to healthcare is also a critical measure of citizenship, dignity, and equality. This is because it influences educational opportunities, economic participation, family and societal well-being, and ultimately national development. When women are unable to access quality health care, whether because of poverty, discrimination, disability, conflicts, restrictive policy frameworks, the consequences extend far beyond individual lives. They affect the achievements of sustainable development itself. International law provides us a robust framework for protecting women's rights to health. Yet, as we know, the real challenge is not always the absence of legal standards, but the gap between legal commitments and lived realities. And across many jurisdictions, including Nigeria, women sadly continue to encounter barriers that prevent them from enjoying healthcare that is available, accessible, affordable, acceptable, and of good quality. Bridging that gap requires more than legislation. It calls for accountable institutions, responsive policies, adequate financing, and of course, a deliberate commitment to placing women at the center of healthcare governance. And this is precisely why the work of the Committee on Women, International and Development of the ILA Nigeria is so important. Our committee exists to promote informed dialogue on issues affecting women, girls, and communities through the lens of international law, while encouraging practical, evidence-based solutions that strengthen professionals, but also legal protections and advances sustainable development. We believe that everything we do, from scholarship to our practice, must inform policy, and that laws and policies must respond to lived experiences and meaningful changes achieved when diverse voices come together in constructive dialogue. And today's webinar embodies that mission. We have assembled experts whose perspectives span law, policy, healthcare, and advocacy. Together, they will enable us not only explore the challenges, but also the opportunities to strengthen women's access to healthcare through relevant reform, institutional accountability, and collaborative action. I therefore encourage all of us to participate actively, ask questions, challenge assumptions, and think critically about how the ideas shared today can shape our work as policymakers, academics, professionals, whether in healthcare or law or elsewhere, advocates, and indeed citizens. The conversations we have today should not end with this webinar. They should inspire action that advances the rights of women and girls in our communities and institutions. Before I conclude, allow me to extend a special invitation to everyone participating today. If the issues we are discussing resonate with you, I encourage you to become more actively involved in the work of the ILA Nigeria Committee on Women, International Law and Development. Our committee brings together professionals from various disciplines, academics, policymakers, researchers, and advocates who are committed to advancing gender equality through international law, research, policy engagement, and public education. We welcome fresh ideas, diverse perspectives, and dedicated individuals who are passionate about making a meaningful impact. Today's webinar is just one of many initiatives through which we seek to shape conversations and influence positive change, and we would be most delighted to have you join us on that journey. I'd like to express my sincere appreciation to our distinguished speakers again for generously sharing their expertise. To everyone who has worked behind the scenes to organize today's session, and to every participant, all of you in the room today, for making time to be part of this important conversation. With that, it is my pleasure to welcome you once again formally and to say I look forward to an engaging and impactful discussion. Thank you.
Thank you very much, Dr. Pedi Obani, Chair, ILA Nigeria Committee on Women, International Law and Development. Just a gentle reminder again to our participants that upon entry into the webinar, kindly mute your microphones so that we can enjoy a quiet and yet engaging session without interrupting the speakers. Thank you very much. The event will be moderated by myself, Dr. Ire Okupon, and Dr. Ijoma and Nozie. I will now hand over to Dr. Ijoma and Nozie to moderate the event. Ijoma, you have the floor. Thank you.
Thank you very much, Ire, and welcome, distinguished speakers and participants. So I'll just go ahead and introduce our first speaker for today, Professor Cheluchi Onyemelukwe. I'm going to read out her bio, and then she's going to present her paper. So Professor Cheluchi Onyemelukwe is a leading health law expert in Africa whose work focuses on the right to health. She is managing partner at Health Ethics and Law Consulting, a health law and policy firm, and founder of CHELD, a public health nonprofit organization. She's also professor of health law at the Babcock University, where she has taught since 2013. She previously served as legal advisor on the international health regulations for the WHO in Geneva. She has advised internationally, regionally, and nationally on universal health coverage, women's health, health scrutiny, and health financing for WHO, the World Bank, among others. She is chair of Nigeria's National Gender in Health Technical Committee. She's also chair of Nigeria's National Task Force on decriminalization of attempted suicide. Professor Cheluchi holds a doctorate degree in law from Dalhousie University, Canada, and a first-class degree in law from the University of Nigeria. She is the recipient of many academic awards. She was called to the Nigerian bar. Okay, she's called to the Nigerian bar. Most recently, she was awarded the Access Bank Power of 100 Women Africa Award in 2025 for her leadership in health law in Africa. Outside her professional engagements, she is critically acclaimed and award-winning writer. Let us make welcome Professor Cheluchi Onyemelukwe. She'll be discussing the right to health. There's a reason she's the first speaker. She's going to give us an overview of the right to healthcare. You're welcome, Prof. Please, you can take the virtual.
Thank you very much for that kind introduction, Dr. Ijoma. It's a pleasure to be here. Let me appreciate the committee for taking on this extremely important and meaningful area of international law, and an area that many women in the room would say is long overdue. So thank you so very much. It's my pleasure to be here. I have a very short time to speak, so I'm going to get into it right away. 1 second as I share. Please let me know when you can see my screen. Can you see my screen? Can anyone see my screen?
Yes, Prof.
Yes, we
We can
can,
see
Prof.
it.
Yes, we
Okay,
can.
great. Thank you very much. I'll be speaking today on the right to health of women in Africa, unpacking the myths. My remit really is to unpack the right, to talk about what the right means, what the right, where the right is situated in international law and national law, and I'll add on a few things which I then hope the other speakers will go on to probably expatiate on. So typically when we talk about rights, some of us who work in the space, and I imagine several of us in the room work in the space, it can seem to us that, the concept of rights is just something that we teach in classrooms, etc. But my suggestion to you this afternoon is that we must think about it a bit more broadly. So what are human rights? Why do human rights matter? And what does the right to health really mean? And why should we focus on women's right to health? In essence, this is my whole conversation. As many of us in the room would know, whether as lawyers, international lawyers, human rights lawyers, or even regular people, human rights are entitlements possessed by all human beings as a result of being human. What this does is take the concept of rights outside charity, outside even empathy, as important as that concept is in itself, and situated squarely in the context of obligation. In essence, what it means is that we are entitled, we have these rights where our governments are obligated to confer on us these rights, whatever they may be. And today for us, it is the right to health. We recognize that they're inherent. We recognize that they are possessed by all humans just by virtue of being humans, irrespective of nationality, of race, of ethnicity, of religion, of gender, or any other status, low income status, high income status, whatever that is. They are intrinsic to every human being and are not necessarily conferred upon us by states. Of course, those of us who are experts in international law know that, we can make those distinctions between fundamental rights and human rights, etc. But it is essential to recognize that the concept of human rights is intrinsic to us, is inalienable as well. So it is conceived and devised as a shield to safeguard individuals, to safeguard each one of us, and they operate as rules and they dictate what is acceptable conduct by each of us, but also by the authorities that are above us. So many of us will recognize this as cliches, but it's very important that we lay this foundation, because if we understand this foundation, when we then talk about women's rights to health, it becomes quickly clear that these are rights that women all over the world, women in Africa, women in Nigeria, should be able to claim and claim using different avenues. So human rights are inalienable, they are invisible, they are interdependent, and they are interrelated. And of course, what that means for us in terms of interdependence is that, you know, the right to health is dependent, for example, on a variety of rights, whether it is the right to clean water, whether it's the right to a healthy environment, whether it's the right to being able to exercise other kinds of rights that I may not have mentioned. Human rights are universal, they apply to each one of us, they're not context dependent, and so on. And from a very practical point of view, they give us the language to make demands. They give us a focus for our advocacy. They give us something to begin to change culture with. They give us something to begin to change governance with. Now, when we talk about human rights, we're fundamentally also going to be looking at the international human rights law. International human rights law, there are a variety of them. Many of us in the room would recognize all of this because of the space in which we work. The Universal Declaration on Human Rights from 1948, which is our Bible, the foundation of our human rights, which we put together after the Second World War. We also talk about the International Covenant on Civil and Political Rights and so on, and a whole host of other rights, which I will not mention here for want of time. Now, in each of these instruments, one of the major things that I wanted to set out from there is that they establish the right to non-discrimination, meaning that everybody is entitled to enjoy the rights embedded in each of these covenants, in each of these treaties and international instruments. Now, let me now go directly into the right to health. So the right to health in international law and has already been referred to by the chair when she gave her introductory remarks. The highest attainable standard of care was first recognized in the preamble of the World Health Organization's 1946 Constitution, and it basically captures the right to the highest attainable standard of care for both physical and mental health. Very important to recognize. You also have the right to health set out in other international instruments, the Convention on the Rights of the Child, the Convention on the Rights of Persons with Disabilities. I'm not going to read out all of this, but it's very important that we recognize that across different ways of being and living in the world, that the right to health is well recognized. If you look at the Convention on the Elimination of All Forms of Discrimination Against Women, which for us is critical because we're talking about the right to health of women. If you look at Article 12, it notes that state parties must eliminate discrimination against women in healthcare and ensure that women and men enjoy equal access to healthcare services. It also provides for a guarantee guaranteeing access to family planning information and services on an equal basis. If you look at sub 2 of that article, it requires state parties to ensure that women receive appropriate services during pregnancy, childbirth, and the postnatal period. And when necessary, these services ought to be free of charge, and women should receive adequate nutrition during pregnancy and lactation. Now, these are all, I've talked about specifically CEDAW now, but if we look generally across the range of international human rights instruments, you will see see it quite captured as well. I'm going to take just two of them here. Everyone has the right to a standard of living adequate for the health and well-being of himself and his family. That's Article 25 of the Universal Declaration on Human Rights. And then the International Covenant on Economic, Social, and Cultural Rights, which I'll spend a little bit of time on, also provides for a number of socioeconomic rights, including the right to health. It states that state parties recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, echoing what I had mentioned earlier with the preamble to the WHO Constitution. There are other instruments, for example, the IHR, which came up quite a bit in the context of COVID-19, and so on. And in essence, has some provisions around protecting travelers and their rights as they travel. Also, right to health for migrant workers, etc., internally displaced persons, and so on. Guiding principles on internal displacement. While this does not rise to this level of very hard international law, as we have stated, also very critical as a guide for states. You have the right to health also captured in the UNCTAD, the protocol on trafficking, the anti-trafficking protocol, which requires that all victims of trafficking in persons, including the provision, get support for psychological and social recovery, including the provision of medical, psychological, and material assistance. This is, of course, critical. Those of us in the Nigerian context know that women are more likely to be trafficked. And so this is a provision that, of course, holds quite a bit of relevance. Let me now come down to the regional instruments. At the regional level, we have the African Charter on Human and People's Rights, which provides for the right to health in Article 16. Article 16 requires state parties to recognize every individual's right to enjoy the best attainable state of physical and mental health, and to take necessary measures to protect the health of their people, ensuring access to medical care for those who are sick. Now, I'm going to talk about the Maputo Protocol in a little bit, but let me move on and then I'll settle in on that. Now, the right to health here, we also have other provisions, the African Charter on the rights and welfare of children, also using similar language to provide for the right to health. Now, the Maputo Protocol, which is sometimes called the Women's Protocol, is the protocol to the African Charter on Human and People's Rights on the Rights of Women in Africa. Why is the protocol important? It is the first African treaty to recognize women's sexual and reproductive health and rights explicitly. It provides a substantive equality approach by addressing structural barriers that prevent women from enjoying equal access to healthcare. And it goes beyond recognizing rights by imposing positive obligations on states to remove discrimination and improve access to health services. What does it really provide? So it gives us a very strong foundation for advancing women's health, dignity, and autonomy in the African context. As we know, the African Charter has been adopted across all African countries, and in many African countries, particularly those that practice a dualist system like Nigeria, the African Charter is actually law in the Nigerian context. It's domestic law, which can be enforced and has been enforced in courts. I'm not going to go into the jurisprudence because we don't have that time. But let's look at some of the rights.
You have 5 minutes more. I'm sorry, Prof.
Okay.
Yeah, 5 minutes more.
Thank you. So the protocol guarantees sexual and reproductive health and other kinds of health, and a few other most critical things: protection against harmful practices, including FGM and child marriage. Very importantly, in Article 14, it recognizes health and reproductive rights very critically. In this protocol, for those who work particularly in sexual and reproductive health and rights, also makes provisions around medical abortion in specified circumstances. Happy to take questions on that later. I'm going to skip some of these slides and get to where I really needed to go. So when we talk about unpacking the right, there are a few things that we need to capture. Here, if you look at the general comment that unpacks the right under the ICESCR, you have availability, you have accessibility, you have acceptability, and you have quality as very key concepts or constructs when we think about what health should be. That there should be availability of medicines, there should be accessibility, both physical and financial, etc. And of course, it should be of high quality. You will find the same thing when we look at the right to health in the African human rights system, breaking down Article 16 of the African Charter. There are a few other things that we have, I probably would have liked to spend time on, but I'll say that very quickly. When you look at the rights, so people say, can this be realized? And then you look at we have a concept of progressive realization, which basically requires us to require states to ensure that they realize the rights in a progressive way. We know that everything cannot be done in one day, but what steps are you taking to incrementally and gradually realize the rights? You will find that the right to health is captured in different constitutions around the world. In South Africa, in Rwanda, in Uganda, in Burundi, in Kenya. In Nigeria, it is captured really under the National Health Act, which provides for the basic minimum package of health services. So here, as I end, I ask the question, why do women still struggle? If we recognize that this is a right that should be given to everybody, why should women struggle? And what are the possible solutions to implementation, to enforcement of these rights? Some of the struggles are financial. I have some of that. I hope you can see my screen. Some of them are legal. Some of them are geographic. Some of them are institutional. Now to the myths and get into my conclusion. One of the myths that we have is that women's health is simply about maternal health. I think the maternal health is extremely important, and nobody in Nigeria would say different, given the fact that we have extremely high maternal mortality rates, putting us at, almost the worst country in that respect. But women's health is way broader than this. It spans the entire life course from adolescence to older age and includes everything, the whole gamut. And as we are realizing, there are gendered issues around whether you're talking about mental health. Last week, I was doing some work on mental health, whether you're looking at mental health and, and so on, particularly in the context of maternal health, but also other kinds of NCDs, cancers, etc. Another myth is that passing laws automatically improves access. And of course, as we have already heard today, implementation is critical. A few other things around access, equity, and health systems that I think that we have to look at very critically. We have to adopt an intersectional lens and realize that when we talk about women, we're talking about different kinds of women facing different kinds of issues, whether they be IDPs or women with disabilities or women with HIV, etc. And then there are, of course, our sexual and reproductive health issues, but also emerging health governance challenges and asking where women fit into different things. When we're talking about AI and digital health, whether we're talking about health insurance, for example, I don't have a lot of time, but there's someone speaking on health insurance here, where we realize that women tend to not have health insurance, tend to not get health insurance. We need to ask questions about how we incentivize and increase access for women. And you cannot ask that in isolation. You have to ask it separately or in different ways. When we look at climate change and health, there are gendered issues there. I had a picture I wanted to put here of a primary healthcare center under water, because of floods and all of that. And that was a maternity care center. So who do you think lost out in that regard? That would have been women. So there's so many questions we have to ask ourselves when we're thinking about the right to health. How can the law address high maternal mortality rates? Should abortion remain criminalized? Should the law mandate the availability of menstrual hygiene products in school? All of these questions, and I hope that you can see my screen and see others that I have not mentioned, are all right to health questions for women. I'm going to skip all of this. So what should governments prioritize? We need to strengthen primary health care, and we have to look at things in a gendered way. We need to invest in UHC and ask, how are women captured within the efforts that we're making for UHC? We need to enforce anti-discrimination laws. We need to link different types of services. I wish I had a lot of time. I would have talked about sexual and gender-based violence, for example, and the link to health and how we strengthen some of the referral pathways that we have in that regard. In conclusion, I think the right to health is critical, and it is not, we have to take it in some ways as a given, and in other ways as not such a given. So the right to health is recognized, as I have set out in my talk this morning, on in international law, but also in domestic law. And I've given you some examples. Some even have, the right to health within their constitutions. And of course, we recognize the constitutions as the fundamental law of the land, the highest form of law in a country. It ought to extend beyond legal recognition, however, so that we actually then take the right and make something of it. So it requires effective implementation. Every woman should have access to timely, available, accessible, acceptable, and quality healthcare without discrimination. So if you look at the unpacking that we did in terms of the general comment, what the right to health actually looks like in real life, we have to start asking ourselves, where do women fit in within those blocks of acceptability, quality, availability, and accessibility? Laws and policies are essential. They are essential. Let me not make light of that fact, because you know that we have fought many battles. We fought the battle in Nigeria, for example, on the passage of the Violence Against Persons Prohibition Act and laws of different states. We have fought many battles. We continue to fight battles. For example, we know what has happened with, for example, the gender and equalities bill that has been at the National Assembly for years. So I'm not saying that it is simply a given. Many of us who have been involved in this space for a long time know what it took to have that provision in Section 3 of the National Health Act. But now that we have come so far, we must translate these rights into lived realities, and we have to do that looking at the standards that have been set in international human rights law, particularly the International Human Right to Health. Thank you very much for your attention, and I look forward to our conversations after this.
Thank you very much, Prof. I wish we had more time. It was such an insightful and informative session, and you really set the ball rolling, touching up on everything, around women's right to health. Thank you very much for that, Prof. Yeah. Okay, so we're going to be taking the second speaker, and the second speaker is Nurse Shola Aketi. So I'm going to read out her bio at this time. Nurse Bernice Olushola Aketi is one of the most influential voices in Nigeria and West African nursing. With over 3 decades of leadership, education, and innovation, she has helped shape nursing practice and policy in Nigeria and beyond. As immediate past director of the nursing services at the Lagos State Ministry of Health, she is recognized nationally and internationally for her transformative contributions. Her academic journey reflects a lifelong commitment to growth, with qualifications including Diploma in Nursing Administration, a BNSC, MSc, and a PhD in progress. From 1994 to 1997, Nurse Aketi served at Lagos State University Teaching Hospital as ward manager, head of surgical nursing, and chair of the nurses research team, leading groundbreaking projects that advanced nursing care. A public health consultant and educationist, Nurse Aketi's work has earned multiple awards, such as the African Health Award for Excellence in Nursing and Midwifery by Zenith Global UK, and the 2025 Nigeria Health Excellence Award in Nursing and Midwifery, among others. She is also a recipient of the 2025 National Health Excellence Award in Nursing and Midwifery. And today, Nurse Aketi is going to be taking us on the topic sociocultural hurdles and point of care realities in women's healthcare. You're very welcome, Nurse Aketi. You have the virtual mic now. Hello, Nurse Aketi. Are you here with us? Is she here with us, or should I call on the next speaker? Okay, she probably has a problem with joining. Can everyone hear me?
I can.
Yeah. Yes, we can.
Okay.
We
Yes.
can. We can hear you.
Okay. Okay, so that's fine. Nike, please, do you know if she's on this call? If she's not, let me just go on to the next speaker.
Yes, she was here, but it would appear that she has left the meeting. So maybe we do progress to the next speaker.
Okay. Okay, but can you confirm if the next speaker is on the call? So that I'll know.
Please allow Miss Aketi to come in. She's waiting. I think she's waiting to be
Oh, is she
let
at the
into the
waiting
meeting.
room?
Yes.
Okay, please.
She's in the lobby.
We can't see her in the lobby though.
Okay.
Perhaps we could go to the next speaker and
Okay,
then.
so, okay, and
Thank
then
you.
she will. Okay, thank you very much. Okay, so the next speaker will be Dr. Betty Agala. Is she on the call?
Present, ma'am.
All right. Oh, thank you very much. Okay, so Dr. Betty Agala is a seasoned public health physician, visionary leader, and a passionate advocate for accessible, equitable healthcare in Nigeria. A highly respectful figure in Nigeria's medical community, Dr. Agala has held several leadership roles in the Medical Women's Association of Nigeria at both national and the River State levels. Through her leadership and as the immediate past national coordinator, she has championed initiatives on maternal and health care, maternal and child health, preventive health care, mentorship for female medical professionals, and health advocacy campaigns targeting on the underserved communities. She currently serves as the Executive Secretary and CEO of the River State Contributory Health Protection Program, where she is driving strategic policies and innovative solutions to ensure universal health coverage and strengthen the state's health financing system. Her visionary leadership has helped build more inclusive, sustainable healthcare structures that prioritize affordability and accessibility for all. In addition to her clinical expertise and administrative leadership, Dr. Agala is a social entrepreneur dedicated to creating innovative solutions to bridge gaps in healthcare delivery. She continues to design and champion programs that address systemic barriers in quality healthcare, empower vulnerable populations, and promote healthcare equity. Through her widely acclaimed radio program, Health Affairs with Dr. Vetty, she has educated and inspired millions, bridging the gap between healthcare policies and grassroots engagement. Over the years, Dr. Agala has received numerous awards and recognitions for her service and contribution to medicine, public health, community impact, and leadership. Let us make welcome Dr. Agala as she takes on the topic evaluating equity and systemic gaps in healthcare insurance for women. You're welcome, Doc. You have the virtual mic.
Thank you very much. Thank you, ILA Nigeria, for this opportunity. And please confirm that you can hear me.
Yes, we can.
Awesome. Thanks to Professor Chelucci. I think she and I did some work a couple of years ago in River State when she was supporting WHO on health financing. So it was good to hear her this morning. We don't have so much time. I'm going to try to answer two questions with my presentation. How has equity in health insurance been achieved from a state level perspective in Nigeria? And the second question will be, is universal health coverage achievable for women? And where are we? Cheluchi talked about the right, and all of us do have rights. But while we're at it, can we put on the chat box, if you can hear me, what do you think is the greatest barrier to women's access to healthcare? Just put it up there, whatever you think. Is it the cost of care? Is it geographical distance? Is it our culture, tradition? What do you think is the costs of inaccess to women or inequitable access, whatever it is, just drop it on the comment section and I will see that. So please, can you move on to like the third or fourth slide? We are moving. Yeah, so trying to set the stage, I had asked a couple of questions around what we think is the barrier. Some people may actually say, oh, cost of care is high. Some people may say the distance, we don't even have the facilities, they are not available, or they are available, but there's no financial access, they are not affordable, or we can't accept this kind of care, or the care is there, but it's of low quality. Okay, so in setting the stage, I'd like to say that this conversation around why women's health equity matters is because across sub-Saharan Africa, women face several barriers. Women are the carers, we are the bearers, we are the rearers in the society. We play multiple roles, balancing informal work with formal work, from the girl child through the phases of life. And so you find that we are excluded even financially, economically, and all of these exclusions or barriers are not limited to Nigeria. Across sub-Saharan Africa, you find that women have compounding barriers to quality healthcare. And all of this is happening even in Nigeria. We are not an exception. So understanding the structural forces that shape this, the cultural landscape, and how health insurance works, what the National Health Law Act says, how we are implementing it, understanding all of this is going to take us a step further to ensuring that women can access equitable health care. So out-of-pocket costs have remained very, very high. And this is across both gender. And that's like how most people in Nigeria are paying for health, whether vulnerable or not. So we constantly on a daily basis are pushing vulnerable people into catastrophic health spending, and some people just totally avoid going to the facilities or going to access care. There are structural gaps that we've talked about. Some places don't have facilities, even the primary healthcare facilities, they don't have. Some places, they may be there, but we don't have the HRO, we don't have any form of quality healthcare, being given to the women or men for that matter. And so you can imagine how much more it is that it affects women. The social determinants of health, literacy level, decision-making power, all of these further restrict women, from accessing healthcare. And so having set that stage, and we understand that this is the current situation, not just in Nigeria, sub-Saharan Africa, but also at the state level, we begin to look at what we're doing concerning this. And I'm going to define what equity is as we go on. But let's talk about the Rivers State Contributory Health Protection Program, because that's the state level structure we'll be using for the health insurance assets we're talking about. RIFCHIP is an agency of the Rivers State Ministry of Health. It is established by law and operationalized to ensure that everyone that lives and works in Rivers State can have access to quality health care without going through financial hardship. So our mandate is to provide accessible, affordable, acceptable quality healthcare, which is also timely, because these are all the indices that we use to ensure that people can actually access quality healthcare. We are a social health insurance agency, meaning that we are not risk-based. You don't pay based on the risk you carry, or you know what I mean. Or you don't just come in because you can afford, and then those who cannot afford are left out. Our focus is the entire population, because our mandate is universal health coverage, which is that everyone everywhere can access the health care that they need of sufficient quality to be effective without going through financial hardship. So it must be timely when they need it. It must be there when they need it without barriers. And it must be affordable so that they are not pushed further into poverty. And so our population focus is across board, but different policy plans, are available to different categories of people. Of course, the agency is a proper agency with all the departments, MDAs. There is a board, that ensures that the activities of the agency are supervised. There's a CEO, of which, of course, I'm privileged to be. So let's talk about equity in practice. Equity is actually not equality. So there's equality, meaning that everybody can get the same thing. But when we talk about equity, equity means that I get what I need based on my peculiarities. You get what you need based on your peculiarities, not based on your financial capability. So equity is ensuring that every individual, regardless of their gender, their income, geographical location, social status, can have the health services that they need. At the state level, what equity demands is that we must ensure that those who are vulnerable are in the pool. We must ensure that those in the formal sector are in the pool. We must ensure that those in the informal sector, who make up more than 60–70% of the population, are also in that pool, so that we have a pool that is universal or unitary, and it's able to meet the needs of everybody. So we don't have a pool that is just women or is just men that have a particular set of needs, but that everybody can come in. So those who can pay through the formal sector pay equitably by pay point deductions. And that is done using a percentage. So for us, we do like a 5% of the basic salary of that enrollee. And of course, it covers that person as a principal, the spouse, and 4 children. Now, for the informal sector, we have
Excuse me,
premium.
doctor. Excuse me, doc. You have 5 minutes, please.
Oh, that's fine. We have premium that are affordable for different categories of people. And then the informal sector, the vulnerable population, those who cannot pay at all. The National Health Act, through the Basic Healthcare Provision Fund, ensures that we can provide the minimum benefit package of health services. And so these people can still be part of the scheme, even though they cannot pay. And so we are zeroing in on women, and we find that in our enrollment trends, there are more women. So as we speak today, we have 63% female enrollees. And these women are not accessing only maternal and child care services. They are accessing services across the age range. Women are having fibroid operations, women are being treated for hypertension, and all of that. So our enrollment trends show that women are prioritized in the access to healthcare. Our benefit package covers services across the range of the different phases of women's life. And in Rivers State, across the 23 LGAs, we currently have at least 205 healthcare facilities, primary healthcare facilities that provide service. We have 23 local government areas and 23 general hospitals that provide service. And we also have private hospitals around the state that also provide services. So what is being done and how are we able to do this and what more can be done? Of course, we've talked about the legislative anchoring. There is a law, so it's not something that after today is going to phase out. So there is a law, there's a legal standing on which this MDA has been established. There's a subsidy by the government, both at the federal and the state level, to provide the Basic Healthcare Provision Fund in counterpart, and then the equity where state takes care of more vulnerable persons in the scheme. We have drives across communities, across different media to ensure that many more people can come in. Of course, we accredit our facilities. All of this we are doing because we know, as we try to answer the second question, that universal health coverage for women is achievable. And how RIFCHIP is implementing is what is happening across the 36 plus 1 states in the country. So what we're doing here is the same thing that is happening in Lagos, is happening in Abuja, because it's a national drive. But we know that the people are in the community. The poor women are at home on the farm, and it is only through the community that they can have this access to care. So yes, it is possible. Looking at gender gap, I think we actually prioritize women. Hitherto, men hardly go to the hospital. I think they just think that the hospitals are for just maternal and child care. But with what we're doing, we're able to raise awareness, which is one of the challenges we've had as a country over time. People are unaware, there's ignorance. So they don't know the access that they can have. They don't know the range of services that are there. They don't know that they can actually go to the hospital just for a check. You don't even need to be sick. So Rivers State reflects the national pattern, and we're trying to bridge this gender enrollment gap. And of course, we think that it still requires a proactive policy intervention. It requires flexible contributions, some of which we are doing, working with groups to see how we can get them into the scheme, even without making it too difficult for them to pay. We are ensuring that community agents are trained to help at the level of the community. We can't be everywhere, but we work with community structures And we are using the maternal health as a litmus test for equity. Yes, Dr. Cheluchi said something about women's health not just being maternal health, but that's one of the indices that is used even in measuring the development of any country, any nation. So maternal health is the litmus test that we can use for equity at this point. And Nigeria's maternal mortality ratio remains one of the highest globally. So definitely our drive is to ensure that everyone that is pregnant is registered. So we work with the primary healthcare management board in River State to ensure that every woman that walks into the health center gets registered into the scheme, not just because they cannot deliver in the facility and go, but because of that 1, 2, 3 woman who would require either an assisted vaginal delivery or a cesarean delivery. And of course, we know that they are unable to pay for that. So from River State, what works, what we need to reform is that this scheme is working and it is pro-poor, right? It is pro-gender or it's pro-women. We have this legislative framework that is helping us, to drive the agenda forward. The multi-stakeholder governance structure is also helping us, and we are gradually expanding coverage, not just for enrollees, but making the geographical distances shorter and shorter. And so we're having more private practitioners see our clients. We're accrediting them, and we are integrating all of this into the existing care infrastructure in the streets, both the primary, secondary, and tertiary. So what we think needs to be done as we are wrapping up is to ensure that the legislation is, though what we have is more like pro-poor, let me put it that way. But for us to look at vulnerability of the woman generally, persons living with disability, the poor economic power that we have, all of that, we may need to put this in our laws, in our policies. And we also need to expand informal sector enrollment pathways. And that's something that different states are pioneering, getting adoption models, how to get more women to come in. We also need to look at the kind of data we are generating. What are we looking at? What do we want to see? That will help us from the point of service to generate the right data that can help us to make informed decisions as we continue to ensure that we have key health workers on ground, not just facilities, but we have people on ground that can actually provide these health services in our remote communities. So our takeaways is that equity is a choice, and we are making the choice to ensure that it happens for women, and that everyone, indeed, who is vulnerable can be given a playing ground, not level playing ground now, but that level that they need to be able to see above the fence. So it requires deliberate policy design, targeted resource allocation for this, and unwavering political commitment. We know that nothing much works if we don't have that political commitment part time to push these policies for us to be able to implement them to get the right outcomes. At River State, we have some of the legislation that we need. We have the financial instruments, and we can serve, just like other state social health insurance agencies, we can serve as national models for responsive, gender responsive, equitable healthcare for women. And of course, we believe that UHC is within reach. We are not where we used to be. We are not yet where we are going to, but we have made some significant progress. And through the state social health insurance agencies, we continue to make progress. So I want to thank us, and I'm hoping that maybe with questions that come up, specific questions, I'll be able to expand on why I think that UHC is possible for women. Equitable access to healthcare is possible. Thank you very much. Thank you for that opportunity.
Thank you very much, Dr. Vetty Agala, for your very insightful perspective as well. So without wasting time, I'm going to Aketi. I believe she's in now. Is she in?
Yes, I'm in. So the
Okay,
network
beautiful.
disruption, apologies for my side. And I take it as the last presenter. So when you called me, I was just trying to call me before Dr. Petty. Thank you.
It's fine. I'm sorry about the network issue. So Nurse Aketi is going to take us on the topic sociocultural hurdles and point of care realities in women's healthcare. So madam, just take it off from there. Thank you.
Good afternoon, Director and the eminent in the house. I joined Professor Chul when she was presenting, and that was mind-blowing. Thank you for that presentation. And for Dr. Vetty to follow it up as well. And having worked on the same route before now, I think that makes you to be able to speak well to the presentation. Thank you and God bless. However, I see it as an opportunity for me to thank the entire team for inviting me to this laudable event. As rightly said, I'm Shola Aketi. I'm just an SY Director Nursing Services, Lagos State Ministry of Health. Sociocultural hurdles and point of care. Thank you for this topic in women healthcare in Nigeria. The last speaker said that women are not the only one they cared for, but I take it that women are the reproductive organ of our system. How do I mean? They produce another generation, and the more reason they should be well preserved and be considered in enabling them to go through it. Why this context, as a matter of fact? We say women constitute nearly half of the population. This we can attest to. And not only that, they take most of the responsibilities that are even supposed to be taken by our men folks. So addressing these issues requires understanding from all sectors in order to prevent the tearing challenges they both face. What are the burden of maternal health? Because we have limited time. Precisely, we look at it from the angle of what affects women predominantly. As we can say for now, nationally, about 512 deaths per 100,000 live births were recorded for women. So maternal mortality was a great challenge for women. We're even happy for Lagos and possibly Rivers, where we have about 430 or thereabout. But when we get to the northern part of this country, it's more than that. About 1,059 to 100,000 live births. That is huge. And we have what it takes to nip it at the bud. The last speaker speaks of the availability of healthcare workers, but most of these are being experienced at our exterior ends. Vis-a-vis, in Lagos State, I will refer to all our riverines in Bejuleki, exterior end of Badagry, and not to talk of down the Ikorodu. But I'm using Lagos State as a case study because that's where I formidably worked before retirement. I must sincerely say that many works are ongoing, and with align us not to pay out of pocket any longer with the introduction of effective insurance. I want to look at it that we are going to have a better even. The burden extended, not only that, and what are the things that really makes this to be so? So many factors. Japa syndrome was a factor. When you get out of antenatal clinics, you discover that majority of these, out of 75 people that are registered in our hospitals, our facilities, only 32 came thereafter. What happened to the remaining ones? Because culture is dynamic, healthcare is cultural integrated, you find many of these people going back to go and deliver at so-called traditional birth attendants, of whom are not well regulated, of which currently the State is doing a lot in that sphere. Because until we nip it at the bud, we continually be having increase in maternal. And the partners, international collaborators will be saying, what are we using their funds for, their support? And so works is currently ongoing. Why many Nigerians prefer to deliver, study has shown that number one is out of pocket. They said they cannot pay when they get it. Another time they say attitude that we are worked on of the healthcare workers. Another factor precisely is like they believe that when they deliver and there's a complication, they should be able to. So the burden of this has to be taken into consideration. It was discovered that during the presentation, we found out that verbal autopsy brought us clearly what really transpired at our community level. By bringing to bear the community health officers, community midwives, domiciliary, and the likes. Domiciliary nurses are available, and they are the one we are working along with. However, the body goes beyond that. How about the family planning? The former presenter made mention of men also being given the consideration. Yes, but because of our cultural basis, our socio-cultural belief that men should take the decision, women hardly go to family planning to do it on their own. And so we are trying to work alongside with them to ensure that men give them the prerogative and the even support to ensure that the life is being spared. We discovered so many methods, but there are some methods they cannot take without the consent of their husband because of the belief and the system. We discovered before now that this attendance of personnel, skilled birth attendants, were not available. Same also with the application of family planning. Recently, we have an engagement with GSK, and there we're able to understand that the report we got from our community shows that many people try to offer these services. And so there's a need for many of these practitioners to be encouraged to stay at our community events. However, the current situation in the country or across board requires the intervention of everybody to be on the board. Our adolescent girls, those days we are saying teenage pregnancy, it has even gone beyond teenage pregnancy, now extended to boys, going into drugs, substance use, abuse, addiction of various sorts. And it's not any other thing that the presence of the stakeholders to nip it at the board were limited. So it's an encouragement now that we have a lot to do in that regard. I would now need to go back to maternal mental health. Maternal mental health, sorry, I need to just cut it because of our limited time. Maternal mental health has become a public health advocacy, a grave advocacy for all public health officers now. We believe culturally that is as a result of sorcery or otherwise, but we have been able to establish through data and engagement that is not so. Some of these are neglect because of our belief and cultural practices. And I must sincerely tell you, because in our recent studies, it shows that three cardinal things prevails in this maternal mental health. When they are sick and they don't seek for support from the facilities, experts, they take what is available to them. And that's why currently Next Month is doing something. What is it? Liaising with all our transport officers at our about 15 states is being considered, or which 3 states are monitoring currently, that the transport officers should liaise with the facilities available to ensure easy transportation of these people. That will reduce maternal mortality, as well as prompting them to be given the care when needed, especially when they are the complicated environs or stage. However, maternal mental health is another thing that when people put to bed, we ensure that we have a domiciliary midwife that can visit them at home, put them through the necessary stages they should expect and what they should do. Infection,
Sorry,
state
excuse me,
all the
nurse.
challenges they are having, and they will take it to be cultural factor. And so we try as
Excuse me,
much as
please.
possible.
Excuse me, please. You have 5 minutes remaining, Nurse Aketi.
Thank you, ma'am.
Thank you.
So what are the social-cultural barriers, as I mentioned? We mentioned of gender norms, in which women are not supposed to, it was deep-rooted that gender norm restrict women healthcare decision. And that is why, as God has used this platform to get across to women, much still need to be needed and to be done to our local even. Decision power, the cultural expectation limit autonomy of women in seeking health, like I earlier mentioned, the area of family planning. And the influence of the community has to be broadened. Like I said, culture is dynamic, but there are some culture that need to be redefined in order for them to get the best of care. So what are the decision-making power needs to be done? The women should be permitted to significantly indicate what they would like to do, not necessarily under any compulsion. And same thing goes for autonomous that should be given to them. In rounding up, what are the point of care reality that we have? We have shortages of manpower, and we are working around it. For instance, all institutions, nursing institution, department of nursing are being encouraged to increase their intake in order to still have, because the more they go, I mean, we need to increase and produce more. We try to work on the long waiting hours and those factors that could make them or limited them from coming to seek for the health care. There are so many impact of this barrier. This I mentioned earlier on the part of the policy and leaders. The collaboration should continue, and that's why I'm extending this appreciation to the Committee of International Legal Women that put this thing together. And the role of advocacy cannot be overemphasized. Advocacy, advocacy, advocacy. We're able to see that during COVID-19, some measures were put in place with constant media engagement. And so with this legal protection being in place, people will be made to say, oh, I need to do this. When they think there's no legal framework to do that, that might not be 1% or 2% being increased to our budget being increased. What effect does it have? We need to begin to enforce the lawmakers to bring it to reality. In rounding up, because of our limited time, I want to sincerely tell us that women play a significant role in our environment. Like I said, they are the producer. So when we empower women, we reform the system, we save lives. And together, we can dismantle all these barriers through advocacy, further engagement. You engage me because you believe that I have what it takes to share on this table. That started already. And the statistics presented by the previous speakers confirm that a lot needed to be done. More so, not at the rural, but at the urban rather, but at the rural exterior. Currently at Ibejuleki, a lot of work is ongoing in Lagos State with my team. And I'm happy for the outcome that we are getting. Out of pocket should be reduced by ensuring that, we adopt that capitalist system, which everybody benefits for what is available. However, I can tell us that with Nigerian policy reformation that is ongoing and with legal framework, we can get the healthcare system spending more than before. On this note, I want to say, together everybody can empower women and strengthen our system to get the best of women. Thank you for the opportunity. Over.
Thank you very much, Nurse Aketi, for this very enlightening and very insightful perspective as well. So our time is fast spent. Distinguished participants, okay, I see some questions on the chat box. So for those of us who still have questions, please do well to put them in the chat box so that we can ask our experts here. So, but I see two questions from Beatrice Eninuma for Professor Cheluchi Onyemelukwe. So, Prof, she is asking, what legal obligations do states and subnational governments have to provide reasonable accommodation in health facilities. For instance, sign language, interpreters, and accessible examination tables for women and girls living with disability. That's her first question. And the second question is, what mechanisms exist for women and for women with disabilities to seek redress when their right to health is denied at state or facility level? And how can we strengthen those pathways? So these two questions are for Prof. Okay, Prof. I don't know if you can answer those questions in 2 minutes so that we can also attend to some other questions.
Other questions, yeah.
Thank you.
Thank you very much. I think that is another webinar that we have to do, Dr. Nazim. But very good questions in terms of disability. Of course, you know that Nigeria is a party to the CRPD, which I mentioned in my presentation. That's a Convention on the Rights of Persons with Disabilities. And we have domesticated that in part through the Discrimination Against Persons Prohibition, Elimination and Prohibition Act of 2018, the Anti-Discrimination Act. Different states have also adopted the National Act or enacted their own laws. So, for example, Lagos State has had the Special Needs Law for a very, very long time, even before the national domesticated the CRPD. So, in essence, we have legal obligations. If you look at the Act itself, it says that discrimination is prohibited across all institutions, etc. So it comes down again to enforcement. So yes, we need sign language, we need accessible examination tables. Thank you for pointing all of those things out. Braille support for persons with visual impairments and a whole host of other supports. But as you know, and as you know, some of us who work in this space have done quite a bit of work in that space as well, you know, even looking at criminal justice, we know that we have a big gap in that space. And as a matter of fact, the federal government, I know, has taken on some work in that space. At the Federal Ministry of Health, they've set up a technical working group on disabilities in the health space to which I belong, where they are trying to drum up advocacy for some of these things, working also with the National Commission on Persons with Disabilities. So are we where we need to be? We're not. Do we have legal obligations? Does the state have legal obligations? The answer is yes. Some of us have been talking about looking at strategic litigation as a means to push on these. We know that many of our hospitals, many of our health facilities are not accessible at all and have none of the reasonable accommodations that you mentioned. So we have to keep advocating, and I'm happy that we are having this conversation at this level and in different other spaces. And we need to keep advocating and using every means that we have to make this become, you know, practicable in real life. I think we also need to bring private sector into the room so that as people are building facilities, they are actively thinking about these things. In terms of, so yes, we have that, we have the, so I believe that some of those advocacies are necessary at the state level and, you know, in terms of the mechanisms that exist for seeking redress when they are rights. At the state level, you know, we have state disability commissions. I know that they are open to taking complaints. At the moment, those are the only avenues that I can think of. I'm sure there are other softer avenues, but again, we need to sort of strengthen that. And you really make a good point when you talk about the pathways from primary healthcare, the secondary level, general hospitals, etc., to the state disability commissions, etc. I don't know that those pathways exist. In fact, I don't know that, because I know that at the federal level, we have had to really fight to get National Commission on Persons with Disability on board for the health space. So I imagine that at the state level, we don't have as much. Lagos State may be different because Lagos State for a very long time has had their law in place and they are very active. The agency has been very active. If you go to their ministries, the parking spaces and all those sorts of accommodations are enforced. So I imagine that there might be, without going to say, give information that I don't have, I imagine that in Lagos State that there are probably pathways. But in many other states that I've worked in, this is very new. This is recent, but I thank God that we're beginning to have these conversations and you raise very, very important questions.
Go inside the room.
Dr. Anozie, you're muted.
Thank you very much. Sorry about that. So there's a second question here from Ojoma Rachel, and she's asking, her question is to who now? Okay, let me ask first and then we'll probably find out who the question is meant for. So our question is, what institutional frameworks exist to bridge the gender gaps and quality of healthcare at the IDP camps? I don't know which of our experts.
I can take that very quickly. I can take that very quickly because I work in IDP camps as well. I would like to say that we're doing extremely well, but the truth is that there are serious gaps in those spaces. So in some of the IDP camps that we have worked, the Federal Ministry of Humanitarian Affairs that is in charge of NCFRMI, as the National Commission for Refugees, Migrants, and Internally Displaced Persons, actually does work in those spaces. However, we see that significant gender gaps remain. So, for example, in ensuring that they are part of social protection services like health insurance, because they need all kinds of supports to, what you need to, like your NIN and the rest of that. That's actually the work that we have done in that space to try to link them to those social protection services. But if you go to many of the camps, you find that while there has been some work over time, that is, there are quite a few gaps here and there. Legally speaking, all the health insurance laws, many of which I worked on because I did the model health insurance laws back in 2015, working with the National Health Insurance Scheme at that time, all cover IDPs. Unfortunately, in real life, what we find is that they're not aware, they don't take it on board, and in some areas where there are primary healthcare services, they're able to get services. But if there are no ones that are close by, we find that they deliver in the IDP camps and so on and so forth. So the point again is that I feel like some of these questions are really hinting at where we have gaps and where we need to keep pushing. Thank you.
Thank you very much, Prof. And so we have another set of questions from Minabo Ininuma. I think she has 4 questions. Okay, let me read them out. And the questions are for Dr. Vetty Agala. So the first question is, how does Rivers State Contributory Health Protection Program address extra costs that women with disabilities face, such as assistive devices, personal assistance, and accessible transport to facilities? Okay, have you noted that, Nurse Aketi? Then her second question is, are benefits packages under the Rivers State? Okay, no, this should be for Agala, for Dr. Agala. Okay, are benefit packages under the Rivers State, required to cover disability-specific services such as physiotherapy, rehabilitation, mental health, and assistive technology? And how is that monitored? Then the third question is, what data is Rivers State collecting to track enrollment, utilization, and outcomes for women with disabilities? And how is that data used to close systemic gaps? And then her final question, under the Rivers State chapter, why does it take a day? Why does it take a day to get access code before getting healthcare, especially when on referral? So those questions, Dr. Agala, if you could take them in 2 minutes, we're already out of time, but please just give it a shot to answer the questions in 3 minutes. Thank you.
All right, so thank you very much. I'll start with the last. When we started, we were having challenges with our back end, and so access codes were coming hours later. But we quickly realized that that was not good quality. And so as we speak, within minutes of requests for access code, in fact, within less than 22 minutes, you get your referral code. And that's because we have a mechanism that gets back to the officer in charge. So you have a prompting. It's not just that there's something there, but you get a prompt to check that there is a request for a pre-authorization code. So we've pretty much dealt with that. And that's what data does. When you see the outcome, you get the feedback, you're able to push things around to improve service delivery, which comes to what I said about data. I know when I was talking, I said, what kind of data are we collecting? And so this meeting is so critical because it's now opening our eyes to see what more we can do. Most of our data are pretty much generic, maybe male, female, antenatal, delivery, family planning, you know what I mean? So even though we have a huge percentage of our vulnerable population as persons living with disability, beyond that data and a disaggregation of what disability, there hasn't been any specific follow-up on what kinds of services are they assessing and all of that. So from here on, we will look at that. The other question was, okay, so that speaks to how is the benefit package monitored, right? Sorry.
Sorry about that.
So, yeah, trying to, I'm trying to check.
We'll give you time to take a glass of water.
Yeah.
When we align Dr. Yeti to do that, please take care of that. Very important. I quickly want to bring it in there that in my presentation, I said about 68% of our women, they are not literate as such in terms of accessibility. I want to take the same to be the operational at IDPs. Majority of the IDPs, definitely we need to look at their mental status, fine. But if they were in a way that were enlightened, or they have educational background, that because I said in that presentation that higher education increases healthcare utilization. So we should look at that from that perspective, that the moment they are getting out of their status, we should find a way of encouraging them. They do that at our correctional centers by ensuring that they get engaged with National Open University, so that anything we are telling them, those that are well informed among them can spread the information about the proper way of utilizing the facilities. That's just the little contribution I want to make. Thank you.
Thank you, Nosaketi. There's
Yes,
actually a
I was trying
question.
to look at the questions again.
Okay,
For
please,
now,
you
we
have
don't
1 minute to
cover.
just round up. We're out of time already. Please.
For now, we
Thank
don't
you.
cover devices. We don't cover devices routinely as part of the benefit package. But there have been several interventions. We can do a wheelchair, hearing aids, white cane, and all of that. But as of now in Reef Chip, we haven't had that that need yet. But like I said, as we're having these conversations, it means that we need to begin to cone down on the kind of data that we have so that we can intervene more responsibly. Thank you.
Thank you very much. There are several other questions, but I think you've already addressed them on the chat box. But please prompt me if there's anyone I'm missing. But there are questions for Nurse Aketi from Minabo. And the first one is there any nursing and healthcare facility protocols in effect in Nigeria for training providers on disability, inclusive, respectful maternity care and communication? So that
Thank you
is,
very much, ma.
that is for Nurse Aketi.
Thank you so very much, Bunabo. Yeah.
Please, 1 minute, ma'am.
Oh, yeah. There is a curriculum for communication that cut across in the course of delivery, the protocol that needs to guide the practices. But as regards IDP, it's not fully functional. Why we say so? Because it's not, IDP does not cut across, but we try as much as possible to give the basis during their university or what to do if peradventure they find themselves. With this question, I need to extend it to the council to see how we can include it in our curriculum as a means of improving our curriculum design. But for now, we have that of communication, entrepreneurship, and other things that will make them effectively useful whenever they find themselves in any community.
Thank you very much, Nurse Aketi. So as we round off on this session, let me take the last question, which all three speakers may want to give us their final thoughts in addition to what they have presented. And the question is, how can policymakers, healthcare professionals, and legal practitioners collaborate to ensure that leaving no one behind in SDG 3 and SDG 5 actually includes women and girls with disabilities in budgeting, service design, and monitoring in Nigeria? So while you're getting your thoughts together, I want you to tie that with your final thoughts on the papers you have presented in 1 minute each. Our final takeaway from your presentations. So I'll start with you, Professor Cheluchi. You tie it together with this last question. Thank you.
Okay, thank you very much. I think my presentation established the fact that we have to look at healthcare as a fundamental right for every woman. But we also have to recognize that women are diverse, that we're not homogeneous, that we have all different kinds of ways of living and being in the world. And I think that that is what that last question on disability is driving at. I'm going to leave it at saying that we just continue to need advocacy. Almost of the legislation that we have in place, laws on health insurance, for example, the Vulnerable Group Fund under the National Health Insurance Authority Act, amongst other things, and the National Mental Health Policy and National Mental Health Act, much of which I have contributed to, move in favor of ensuring that different kinds of people, persons with disability, women living in IDP camps, and so on and so forth, are protected. We now need to make sure that they become reality. And I'm so happy that we invited Dr. Vetti. Dr. Vetti has been a champion for universal health coverage in Rivers State, and we happen to work together on basically setting up this agency which is running. And I know and I believe her when she says we're going to go back and we're going to look at the data on disability. And my hope is that the communique here will help us, continue to spread the message that we have to look at women in their diverse forms and make sure that when we say universal health coverage, we really, really mean universal. Over.
Thank you. And then Nurse Aketi, your final words tied together with the question on the chat box. 1 minute, please. Thank you. Okay, she doesn't seem to be ready. Dr. Vetty, please. Thank you. Your final words in 1
All right.
minute.
Yes, thank you so much. What I want to say is that women living with disability have to be part of the advocacy. So they need to, I know they have groups. We need to work with them to understand their needs beyond what is in policy documents, but to understand their needs as to those that have access, those that don't, those that have access, but it seems like the access is not acceptable or it's not of good quality. We need to work with them to drive that agenda, because most times we look at women, but we forget that we are actually at different phases with different unique challenges as different groups. So I think that physical disability, those living with physical disability, they need to form coalitions, and then that advocacy needs to come down to the community, because for some it's basically being unaware of what is even available. Talk more of um, those that are not even available. So I'll end it there and say thank you for inviting me on this call.
Thank you very much, Dr. Agala. Do we have Nurse Aketi now?
Yeah, I'm in the house. Did you call me
Okay,
before?
please.
Yeah.
Yes, I did.
Oh, so
Apparently, the
sorry.
network
I
didn't
think
let you
this
hear me,
network
so that's fine.
sometimes it must be
Yes,
intermittent disruption. I'm sorry.
it's
However,
okay. Yeah. So your
while
final words in
appreciating,
1 minute, please.
yeah,
Thank
while
you.
appreciating the organization for this laudable event, I want to emphasize on the two previous speakers that social inclusiveness of Lagos State has added to their Themes Plus agenda is of vital instrument. Everybody counts. Equity, not equitable. And by my final note, I want to say that improving women's health care in Nigeria requires more than medicine. It requires understanding the culture. Culture is dynamic, empowering the women, and as well as strengthening the healthcare system in which we are all premising our discussion upon. Thank you for the opportunity. Over.
Thank you very much. The day is far gone. So we have come to the end of this program. And I would like to thank the host of today's webinar, the chair of the ILA Nigeria Committee on Women, International Law and Development, Dr. Pedi Obani, under whose leadership this has been made possible. Our distinguished experts and speakers, starting with Professor Cheluchi Onyemelukwe, Nurse Shola Aketi, and Dr. Vetty Agala, for your well-researched and insightful and quite informative presentations. We have really, really gained so much and learned a lot from your presentations. Thank you so, so much. We also thank our distinguished participants for their time, for your time, and for your engagement in making this session very interesting, and also throwing more lights in even areas that, the speakers hadn't planned to speak on. But from your questions and your interactions, you made it possible for us to learn a lot more. Finally, I sincerely also appreciate the efforts of the committee, the ILA Committee on Women, International Law and Development, particularly the Health Webinar Subcommittee, for pulling this off. Thank you so much. We know how hard we all worked to make this happen today. And please, everybody here listening, don't forget that we have our webinars also coming up in September and October. For that of September, the theme of the webinar is Reproductive Health Forum, Access and Point of Care Realities for Women. That is coming up in sometime late in September. You will all be notified. And then for the one in October, it's going to be Understanding IVF and Surrogacy, the sociocultural, legal, and moral aspects. and this will be happening in October. So it's on this note that I say thank you. And please remember to follow us on our social media handles, the LinkedIn, Twitter, and all other social media handles where we are. And please remember to like and share our information. Thank you very much, everyone. And I think we have to call it a day here now. Thank you.
Thank you. Thank you for inviting me. It's a pleasure.
Yeah.
Well,
Well
thank
done,
you
Dr.
for
Mary.
brilliant facilitation. Thank you, Dr. Pedi, for keeping on at us.
Oh, thank you so
Thank you,
much. And
Dr.
thank you,
Betsy.
Dr.
So good to
Ngozi.
see you here. So
Thank
good to see
you.
you here. Yeah,
Thank
Dr. Betsy.
We appreciate you, Chelichi. In fact, I'm so
Yeah.
excited to.
Yeah.
Why you are
So
still
awesome. And to see you leading it, I mean, it's amazing. It's like we've come full circle.
Yeah,
Wonderful.
finally, we're here. It has
Great. It's
happened.
great.
Well done. Well done.